Can everyone see that?
Yes.
Yeah, great. Thank you. So this is a public workshop on a proposal to add or update health endpoints used in CARB's health analysis. First, some information on programming. We have Spanish interpretation available. The interpretation feature requires downloading the Zoom application. When you open the Zoom app, you will see an interpretation icon that looks like a globe at the bottom. You can click on that icon to see the slides and hear the presentation in English or Spanish. If you select Spanish, please also select mute original audio to stop the English audio. Is our interpreter able
Okay.
to?
I just
Yeah.
was waiting for you to say. Buenos días. Esta es una audiencia pública. Mi nombre es Prarathiva Pradip. Y hoy les vamos a tener la posibilidad de que ustedes puedan escuchar esta audiencia en español. Para poder escuchar en español van a necesitar bajar la aplicación de Zoom en su aparato, ya sea computadora o teléfono, y ustedes van a tener que ir al globo terráqueo que está en la parte de abajo para seleccionar interpretación, y ahí van a seleccionar el idioma en que quieren escuchar la interpretación. Esto automáticamente les podrá hacer la posibilidad de escucharlo. Así también les queremos informar que las diapositivas estarán disponibles en español. Si ustedes van en la parte de abajo en el icono que dice chat, tendrán acceso también para bajarlo. Gracias. Thank you.
Thank you. So today's meeting is also being recorded, and the recording will be posted on CARB's website. Our presentation will be about half an hour long, and after that, we'll respond to public questions and feedback. You can send your questions at any time using the Q&A icon at the bottom. After the presentation, if you have a verbal comment, you can raise your hand to join the speaking queue, and we'll give each commenter 2 minutes. You can also submit written comments anytime in the next 3 weeks, and I'll share directions on how to do that at the end. If your feedback is in another language, we'll respond to you by email after the workshop. So I'll be the facilitator today, and you'll also hear from several CARB staff listed here from the Health and Exposure Assessment Branch. I'll ask those staff to quickly identify themselves now.
Thank you, Pradeep. I'm Arash Mohe, exposure scientist.
Erica Ramsey, environmental epidemiologist.
I'm Joshua Montefalcon, and I'm an epidemiologist.
I am Ninin Aun, and I am a toxicologist.
Good morning, everyone. I'm Feng Chao, so I'm an environmental epidemiologist.
Good morning, everyone. I'm Nargis Jain. I'm a public health scientist.
Thank you. I will now turn it over to Bonnie Holmes-Jen, our branch chief, for opening remarks.
Thank you, Pradeep, and good morning, everyone. Welcome to everyone joining today. I am Bonnie Holmes-Jen. I am the chief of the Health and Exposure Assessment Branch in the Research Division. And I would also like to introduce Elizabeth Shealy, chief of the Research Division, who is leading our agency's research program. CARB is supporting air pollution health research because we know that pollution has profound effects on our lung health and on all the major systems of the body. And we want to inform the public about these impacts, and we want to incorporate them into our health analysis. As we'll discuss as we go forward, our research on health endpoints has expanded recently to cover a broader range of health effects. We are proud of our scientific work to study these health impacts of air pollution and to make sure that we are informed by the best science. This is the second workshop we've held on health endpoints as we are moving to greatly expand the list of health outcomes that we include in our evaluation of CARB's rules and programs. This workshop builds on the strong record of scientific work that has been accomplished over the years by EPA, in fact, over the past decade, in researching the health effects and outcomes of particle pollution and developing an important benefits assessment tool called BenMap that informs our work. We've also built on EPA's past work by conducting our own research in California to better understand the types and levels of effects that people are experiencing from air pollution. And we are using the results to update and expand our health analysis, as we'll discuss today. Now that we are expecting attempts to roll back the national health-based standard, our work to document the health impacts of particle pollution is even more important. We appreciate your interest in learning more about the health outcomes of air pollution. We look forward to your input and engagement today, and we'll be providing an opportunity to give written input as well. I'll turn it back to Pradeep.
Thank you, Bonnie. So in today's presentation, briefly, we'll cover what the health endpoints are, why and how we include them, why it's important to update them in CARB's work, and what the specific updates we're proposing are. I'll emphasize that this workshop is not on CARB's health analysis methodology itself. We're not proposing any changes to the methodology. We're specifically focused on the health endpoints considered in the analysis. And we'll close by summarizing next steps and taking public comments. And with that, I will turn it over to Dr. Mohe to begin the presentation.
Thank you, Pradeep. So first, what are health endpoints? A health endpoint is an adverse health outcome used to evaluate quantitative or qualitative impacts from a cause like exposure to air pollution. For today's workshop, we are focusing on exposure to PM2.5 or fine particulate matter. PM2.5 is generated by environmental sources like wildfires or anthropogenic sources like vehicles, power plants, or biomass burning. PM2.5 is inhalable and travels from lungs to other organs, affecting the entire body. These effects, like mortality and hospitalizations, are the health endpoints we estimate to quantify the benefits from CARB policies to improve air quality. So why update the endpoints used in CARB's health analysis? We are updating them because air pollution can cause health effects beyond what CARB is currently quantifying. Here's a visualization of health impacts associated with PM2.5 exposure. On this pyramid, the higher a health outcome is, the more severe it is, like death, and it is relatively less frequent. Conversely, the lower a health outcome is, it is relatively less severe, like asthma medication use, but it affects more people. Until 2023, CARB quantified mortality, ER visits, and hospital admissions, which are in the top two segments of this pyramid. The health endpoints we added in 2023 affect more people, like work loss days and asthma onset. But there is a continuously growing amount of scientific evidence showing new burdens of air pollution on public health. There are more prevalent endpoints like birth-related, metabolic, and reproductive effects. Now, how this relates to CARB's work is that health analysis quantifies the benefits or avoided health burdens due to CARB regulations, plans, and programs to reduce pollution levels. We originally started with 4 endpoints. Our current approach, last updated in 2023, quantifies a subset of 12 types of health benefits from PM2.5 reduction. These are cardiovascular mortality, hospital admissions or emergency department visits for cardiovascular, respiratory, or asthma symptoms, heart attacks, asthma onset and exacerbation, lung cancer incidents, Alzheimer's and Parkinson's diseases, and work loss days. These endpoints are all for adults except for asthma onset and asthma symptoms, which focus on children. All these are discussed in our public bulletin released in November of 2022. The bulletin is available on our health analysis methodology website. Now, our goal is to conduct a more complete evaluation of health benefits of the agency's air quality and climate actions. But why now? In 2016, the World Health Organization, or WHO, published a global assessment of exposure and burden of disease from ambient air pollution. The report is based on scientific studies from around the world demonstrating the many serious health impacts from inhaling PM2.5. In that report, the WHO concluded that air pollution represents the biggest environmental risk to health. 5 years later, the WHO released global air quality guidelines, noting that air pollution is now recognized as the single biggest environmental threat to human health. Both WHO publications are based on data compiled by the Global Burden of Disease, or GBD project, which is the largest study to identify and quantify causes of health loss. Last year, the Institute of Health Metric Evaluation, which conducts the GBD project, and Health Effects Institute published a report showing that globally, air pollution is the second largest risk factor for deaths for all ages and for children under 5. In 2023, this is roughly 8 million air pollution-related deaths, or 1 in 8 deaths worldwide. 96% of these deaths are linked to PM2.5 exposure, making it the largest environmental and occupational risk. What about impacts on quality of life? We can quantify this through disability-adjusted life years, or DALYs. One DALY represents 1 year of healthy life lost, either from premature death or disability. In 2023, GBD project linked ambient PM2.5 exposure to 124 million DALYs. For context, annually, that is equal to 1/3 of US adults losing a healthy year of life. I should note that CARB does not quantify DALYs in our analysis, but we're presenting this to emphasize the established evidence of the health burden of PM2.5. To link PM2.5 exposures to public health impacts for regulatory purposes, we draw from sources like EPA's Integrated Science Assessments, or ISAs. The EPA develops ISAs as part of setting the national ambient air quality standards. ISAs are in-depth reviews of the latest air pollution and health research. In the agency's own words, ISAs accurately reflect the latest scientific knowledge useful in indicating the kind and extent of identifiable effects of public health and welfare, which may be expected from the presence of pollutants in ambient air. The latest ISA for PM2.5 was published in 2019, followed by a supplement in 2022 with newer scientific evidence. Compared to the prior version released in 2009, the latest ISA document covers a tremendous amount of new research, or over 1,800 new scientific studies, leading the agency to state that a large body of scientific evidence spanning many decades clearly demonstrate there are health effects attributed to both short and long-term particulate matter exposure. And EPA's conclusion about those health effects are listed on the right, with long-term PM2.5 exposure having a causal relationship with mortality and cardiovascular effects, a likely to be causal relationship with respiratory effects, nervous system effects, and cancer, and a suggestive of causal relationship with metabolic effects, fertility effects, and birth outcomes. EPA determines causality based on the strength of the studies and the volume of the literature. Suggestive of causal does not mean that those outcomes are any less associated with air pollution exposure, but that there may be fewer studies. As we will cover later, these are the research gaps that CARB and others are trying to address. We also note that in both the ISA and its supplement, EPA identified population subgroups at increased risk of PM2.5 related health effects. This vulnerability varies by factors such as life stage, as in children or adults, pre-existing health conditions like heart disease, race, ethnicity, and individual or community level socioeconomic factors like income and access to healthcare. CARB staff understand that all of these and other factors are important in considering the health impacts from air pollution exposure. We are continuously exploring methods to incorporate localized data on at-risk population in our health analysis. At the same time, there's also evidence that even low PM2.5 concentrations can cause health risks. The Health Effect Institute, which is an independent nonprofit research organization on health effects of air pollution, recently published reports on 3 studies of large population in 3 regions to investigate the health effect of air pollution below the national ambient air quality standards in the US or regional standards in Europe. These studies had large population of 7 to 69 million people across North America and Europe exposed to PM2.5 near or below ambient air quality standards for 16 to 32 years. All 3 studies found PM2.5 exposures were associated with increased mortality, as well as endpoints like lung cancer, stroke, and asthma, to name a few. To bring us back to CARB's work, today's workshop is part of our ongoing work to document the wide-ranging health impacts of PM2.5 pollution and to ensure our health analysis methods are based on the latest available science. This stems from a board resolution in April 2020 for a more comprehensive evaluation of health benefits from California's air quality and climate actions. The resolution has 5 specific directives on expanding our understanding of pollution impacts, vulnerable communities, and analysis approaches. This workshop focuses on the 5th directive to include a range of additional health outcomes linked to pollution exposure.
So I'm going to interrupt really quickly to add that for those who may have joined us late, that throughout the presentation, you can enter questions and comments into the Q&A, and we'll address them at the end. We'll take verbal comments at the end as well. So the second half of our presentation will describe our approach for evaluating the health endpoints. Back to you, Raj.
Thank you, Pradeep. Let's start with how health impacts from air pollution are estimated. The methodology to estimate health benefits associated with reduced air pollution exposure is based on a concentration response function, or CR function, which are reported in epidemiological studies. Here's the general form of the CR function. It calculates the change in health outcomes in a population due to a change in the concentration of a pollutant. Our website has a more comprehensive description of our methodology. For now, let's look at mortality as an example. The first term, population, is the number of people from a specific age group or location who are exposed to a pollutant. Let's look at 30 to 99-year-olds in California. That is a population of 25 million. The second term is baseline incidence rate, or the frequency of the endpoint occurring in the population. Here, we are going to assume 5 deaths per 1,000 people per year. That number is specific to our population, but independent of the cause, which is, in this case, PM2.5 exposure. Now, the beta, or the effect estimate. Epidemiological studies report hazard ratios, or the likelihood of an endpoint occurring over a given time. Beta values represent how the changes in air pollution are related to the changes in the health risk. Here, a health ratio of 1.06 from a 10 microgram per cubic meter increase in PM2.5 yields a beta value of 0.0058. The last term is the change in the pollutant concentration. Let's say PM2.5 increases by 1 microgram per cubic meter. In this example, that increase in exposure to 25 million Californians leads to 720 more premature mortalities per year. On to the specific endpoints. CARB plans to quantify several additional health endpoints for PM2.5. As we discussed earlier, we need effect estimates for each endpoint. We are using a few effect estimates that have been reviewed previously by federal EPA and their science advisors. These were included in US EPA's 2024 technical support document titled Estimating PM2.5 and Ozone Attributable Health Effects. This document describes the studies used to quantify PM2.5 health impacts in US EPA's BenMap software, which stands for Environmental Benefits Mapping and Analysis Program. EPA used robust selection criteria for studies used to quantify health endpoints in their 2024 technical support document. Essentially, the selection criteria prioritize longer-term, more recent cohort studies of broad rather than specific endpoints conducted in representative populations in the US or Canada. Studies of large population sizes exposed to current levels of ambient pollution were also preferred. EPA's 2024 technical support document has in-depth description of all these criteria. Some of the endpoints and effect estimates we are proposing draw from CARB-funded research studies specific to California populations. Let's broadly categorize health endpoints as cardiovascular in red, respiratory in yellow, neurological in blue. Non-specific endpoints are in black. Here are the current endpoints that we talked through earlier. Right now, CARB is proposing 7 health endpoints shown in the right column, 3 of which are updates and 4 of which are new. We are updating effect estimates for non-fatal acute myocardial infarction or heart attacks and work loss days. For asthma symptoms, we are expanding the population from children to all ages. The 4 new endpoints are cardiac arrest, stroke, allergic rhinitis or hay fever, and minor restricted activity days, which brings us to a total of 17 endpoints. In the next several studies, my colleagues will cover each of the updated endpoints, starting with Erica.
Thanks, Arash. I would like to briefly mention that as a part of analyzing health benefits from regulations and plans, CARB first calculates reduced health impacts from a reduction in air pollution and then, using standardized methods, the economic valuation of those reduced impacts. This valuation includes reduced medical costs or lost wages, and the valuation is performed using the same BenMap software used for our health analysis and utilizes California-specific economic data. For the next set of slides on the health endpoints, we will be using the same layout with the significance of the endpoint and the novelty of the scientific evidence on the left. And then on the right, we show the scientific study, including journal and year, that determines the effect estimate or the beta value at the top, and the method for the economic valuation here at the bottom. Please note that while we are presenting the basis of the economic valuation for your information, the focus of this workshop is the health associations only, and we are not going to be taking comments on the economic valuation at this time. That will be addressed in more detail in the bulletin we will publish in early 2026. The first updated and is hospitalizations due to acute myocardial infarction, AMI, also known as heart attack. This endpoint does not include death, and AMI accounts for more than 600,000 hospitalizations annually and captures a health outcome related to short-term PM2.5 exposure. For this endpoint, the new scientific study shown on the top right is US-based and analyzed over 95 million Medicare inpatient hospital claims from the years 2000 to 2012 and used zip code level daily predictions of PM2.5. Each 1 microgram per cubic meter increase in PM2.5 is associated with a 0.11% increase in AMI-related hospitalization risk. Next is cardiac arrest, or a sudden and unexpected halt of heartbeat. This new endpoint has a high rate of fatality. The 3 selected US-based studies strongly support the link between PM2.5 and out-of-hospital cardiac arrest, and also captures an outcome associated with short-term PM2.5 exposure. Additionally, associations between PM2.5 and this endpoint were consistently strongest at shorter lag times, in this case, meaning that symptoms were often experienced on the same day or within 2 days of exposure, rather than over long periods. Each 1 microgram per cubic meter increase in PM2.5 is associated with a 0.46% increase in out-of-hospital cardiac arrest risk. I'll pass it over to Josh.
Thank you, Erica. So one of our new health endpoints is stroke, or the blockage or bursting of blood vessels to or on the surface of the brain. Stroke was the 4th leading cause of death in California in 2021, or nominally responsible for 37 deaths per 100,000 Californians. Older adults face higher risk, and stroke-related hospitalizations increase with both short-term and long-term exposure to PM2.5. The study highlighted here found that long-term PM2.5 exposure has a stronger effect on stroke risk than short-term exposure. This is based on hospital records of adults 65 and older and their daily exposure to PM2.5, and each 1 microgram per cubic meter increase in PM2.5 is associated with a 0.3% increase in stroke risk. This next new endpoint is minor restricted activity days, or days when adults reduce their usual activities because of health issues, but are not severely restricted. For example, missing work or being confined to a bed is too severe to be considered a minor restricted activity day. This endpoint captures effects on both health and quality of life to measure economic impacts of air pollution. The effect estimate here is based on a study of 6 annual health interview surveys and showed that PM2.5 exposure is associated with minor restricted activity days, resulting in work loss and bed disability in adults. Specifically, a 0.7% increase in risk for each 1 microgram per cubic meter increase in PM2.5. And I'll go ahead and pass it over to Nin.
Thanks, Josh. The next endpoint is allergic rhinitis, also known as hay fever, a group of respiratory allergy symptoms. Allergic rhinitis is prevalent across socioeconomic and urban-rural stages. The new study we are using analyzed data from over 70,000 children in the US and extensively examined effects from multiple pollutants. The study found 12.3% of children in Southern California region have experienced this issue. The study reported a significant link between chronic PM2.5 exposure and allergic rhinitis in children. A 1 microgram millicu increase in PM2.5 is associated with a 2.9% increase in the risk of allergic rhinitis. Now I will pass it over to Dr. Su.
Thank you, Ninin. The next health endpoint is an updated one, work loss day. It refers to less severe health conditions like cough and headaches that do not require hospitalization, but can still impose substantial economic burden through sick leaves. The original study that US EPA used for this endpoint is outdated and has a limited exposure assessment. So CARB funded a study to determine an updated health effect estimate that meets the rigorous criteria that EPA used, but also is more recent, represents health effects in California's population, use advanced exposure assessment and analytical methods, and capture economic factors like cost of living that are specific to the state of California. The study showed associations between PM2.5 exposure and increased risk of work loss among Californians. Each 1 microgram per cubic meter increase in PM2.5 exposure is associated with a 2% increase in the risk of work loss day, about 4 times higher than the health impact estimate in the original US EPA study. For economic valuation, we currently use EPA's method, but we also have a California-specific method under review. Now I will pass it over to Nargis. Thank you.
Thank you, Fangchao. The adult asthma symptoms health endpoint can include symptoms such as shortness of breath, coughing, or wheezing, which can result in prescription medication use, hospitalization, or emergency room visits, imposing a substantial economic burden and disrupting people's lives. The US EPA study for this endpoint is outdated, so CARB funded a California-specific study using 7 years of data from a unique dataset of asthma medication use collected by digital sensors worn by participants to monitor their inhaler use. The age of the participants in the study ranged from 4 to 90, but were predominantly adults. The exposure assessment also used high-resolution pollution data and advanced statistical methods. The study found increased asthma medication use associated with PM2.5 exposure among adult Californians. A 1 microgram per cubic meter increase in PM2.5 is associated with a 0.9% increase in medication use. I will now pass it to Pradeep.
Thank you, Nargis. So that covers the 7 updated or new health endpoints that we're proposing today. Here is a summary of the effect estimates and some features of the studies. I'll point out that 2 endpoints, allergic rhinitis and work loss days, have effect estimates roughly an order of magnitude higher than those for other endpoints. This means that those are more prevalent. For the proposed changes, here are estimated annual occurrences for each health outcome. We calculated these for PM2.5 exposure in the year 2023. In California, that is around 180 hospitalizations for cardiac arrest and roughly 2 and 4 times as many hospitalizations from heart attacks and stroke. We also estimate over 200,000 cases of hay fever and millions of days of reduced activity or work loss. And these hospitalizations accrue large healthcare costs for the state. The reduced activity, which has costs from both medication and reduced productivity, also add to the economic burden. We're not presenting that economic valuation here, but we will cover it in the public the public bulletin we're publishing in the next few months. And that brings me to next steps. We appreciate your attention to the workshop. We will accept public comments on the proposed changes to the health endpoints now or online for the next 3 weeks, ending on November 21st. These slides will be on the CARB website, so participants will have access to this material for reference. The bulletin will release early next year. Will describe the studies we covered, the effect estimates, the economic valuation, and our responses to the public comments. And beyond this workshop, let me note that updating the endpoints is just one component of a long-term agency-wide effort to expand our health analysis based on the latest science and incorporate community-level health impacts in CARB's analysis. So for example, we have contracted with 5 health consultants who are separately reviewing the latest health analysis methods to provide individual recommendations based on their areas of expertise on how to incorporate health and equity and population disparities in CARB's health analysis. We are also exploring methods that quantify how the health benefits from CARB regulations are distributed across the state of California. We are also filling in knowledge gaps by funding research in the state, so we have a more comprehensive and quantitative understanding of health impacts from air pollution. Some examples are metabolic health outcomes like diabetes, birth outcomes, neurodegenerative outcomes like cognitive decline, neurodevelopmental outcomes like student test performance, life expectancy, and also geographically clustered outcomes like asthma inhaler use in Southern California. We'll discuss proposals to add these to CARB's health analysis in future workshops, just like the one today. So these projects are managed by presenters you heard from today, but also numerous staff from across the research division. Many of them are attending today to hear from you and respond to your comments. And with that, I will open the floor up for comments. If you have a question, you can type it into the Q&A. If you'd like to speak, please click on the raise hand button to join the speaking queue. We will call on you and unmute you when it's your turn. If you're on the phone, you can dial *9. As a reminder, each speaker will have 2 minutes. So first, I will add Ruth. Okay. I don't see any raised hands.
Will has their
Okay.
hands raised. I'm gonna allow you to unmute yourself now, Will. If you have a comment, please go ahead and provide your comment.
Hi, can you hear me okay? Great.
Yes, go ahead.
Great. So hi, I'm Will Barrett with the American Lung Association, and just very briefly wanted to say thank you for walking through the presentation today. We look forward to kind of looking into this more closely, but I think it speaks to the ongoing commitment by the agency to really take science, move it into the public awareness of the harms of air pollution, and really helps to kind of round out the explanation of what's going on in the air around us and what it means for our health. So I just wanted to say thank you for the ongoing commitment with the last round of updates and this updated discussion today. I think, again, it's really important that we continue to put a strong emphasis on the research and putting that into the public's understanding of the urgency of reducing emissions to protect the health of communities all over the state. So just a quick thank you, and look forward to working with you going forward as the document moves forward. We'll take a look at that. Definitely looking forward to the valuation pieces of it, as we know that we're always kind of behind the curve on understanding the full health benefits of the actions that the agency is taking. So thank you for that, and hope you have a great afternoon. We'll be looking forward to more. Thanks.
Thank you, Will. Yeah, so as everyone knows, the amount of research to robustly establish these health effects comes from not just work funded by CARB, but through all from all researchers across the world. So we really appreciate being able to pull that into regulatory analysis. Any other commenters?
Michael has their hand raised. Michael, I'm gonna give you the permission to unmute yourself.
Thank you. My name is Mike McCarthy. I'm a resident in Riverside and a community organizer. And I appreciate you holding this public workshop, and there's a lot of technical details in here. And I guess I'd just say, as a resident who's interested and also busy doing other things, it's really important for the materials to be provided in advance, at least 2 or 3 days in advance. And so the fact that the English slide deck is not available, there were some things that I didn't catch during the presentation that I wanted to look at the presentation slides for. I can't do so. And so if you want an informed workshop, you need to provide the materials to the residents and the people who are attending the workshop at least a day or two in advance so we can follow along. Otherwise, the comments are, we'll provide written comments later, but it's sort of, you're muting conversation by not providing the materials for people to comment on with a sufficient time to review, just like any public hearing or other sort of public participation process. So I just from a public participation process, we can't be informed, we can't know what we're doing. We can't have questions prepared in advance if we don't have the materials to review before the workshop, not just sort of as a fait accompli that we're just sort of trying to digest on the fly as you're presenting it. That's just not enough time. So I don't want to belabor the point, but I really think that in terms of public participation, we need to have it in advance, just a day or two, but just something we can follow along with, so we can have any questions we have ready, as opposed to sort of trying to come up with comments at the last minute. Thank you so much.
Yeah, thanks, Michael. Yeah, and you're right. So we shared the Spanish version of the slides, but that was only once we started the seminar already. That is something that we should have done. And for what it's worth, I can say that we'll have them for your reference right after this on the CARB website. And any questions that you may have at that point, you can also email us directly. But your point about public participation and being able to advance the material ahead of time is well taken. Thank you.
Linda has their hand raised. Linda, I'm gonna give you permission to unmute yourself if you want to provide a comment.
Thank you very much. First, I just want to echo the thanks for the work that you're doing and for continually expanding the endpoints you're looking at based on new evidence. I'm wondering why you aren't including any adverse reproductive outcomes, especially since that's such a big area of public concern, and also because there's just a growing amount of evidence of the impacts of particulate matter and other air pollutants on reproductive outcomes, even since the 2022 ISA supplement.
So Bonnie, did you want to start?
Sure. I was just going to say thank you for that question, because that is a very important area of research, and we are very pleased that we have a California study. As you mentioned, there's a lot of research out there, very important research, and we also have a California study funded by the Air Resources Board that has just finished up and is going through our research screening review process. And once we have this final report, we're going to be looking carefully at that and looking at bringing that into our next round of health endpoints. So it definitely, I think the staff shared a slide of a number of studies that we have that are just completing or are in the last stages on several health endpoints, including birth outcomes. So it's definitely next on our list, and we're looking at bringing that forward. So thank you for that comment.
Thank you, Bonnie. Miss Margaret has their hand raised. Miss Margaret, I'm gonna, if you want to unmute yourself and provide a comment, please go ahead.
Good morning, everyone. My name is Miss Margaret Gordon. I'm a resident of West Oakland. I am one of the founders of the West Oakland Environmental Indicators Project. I've been here before when the scientists, the technicians, engineers come together and write these reports. And I, like the previous speaker, we should have had some pre-empt sessions about what you want to talk about, especially if you're going to identify certain hotspots or neighborhoods, so we can add some clarity on our experience in dealing with some of these issues and the lack of interpretation and communication on some of the issues that you're uplifting. One of the things that there's a difference between public participation and community participation, and you never clearly understand which audience are you trying to educate or orientate. That is a problem. And then you use language that is not particular to our day-to-day lives, who are living in the impacted or hyper-local communities with these impacts. You never use our language as popular education or non-science layman terms, so we can completely understand what are you trying to communicate with us. That is a problem. There's an ongoing problem with scientists that I think you have good intentions, but how you present your intentions does not really say that we will celebrate the information if we don't have it in a conducive area, areas of that support our day-to-day issues, our long-term issues of polluters, government, and jurisdictions, and other such agencies, other agencies or associations that keep us from understanding how to use the information that you present. But if it's not presented in such a way that is usable, it's moot. Thank you.
I just wanted to thank you, Ms. Margaret, for participating and for your comments. And maybe just as a kind of a broad overview to kind of restate, if it's helpful, what this workshop is about and why we're all here. I hope that's helpful. We have been working here at the Air Board. Well, let's back up a little bit. In the research division, we do a lot of great work, and part of that is sponsoring important research studies. And part of that is we conduct health analysis for all the rules that go through the board. We develop we develop quantified evaluations of the health benefits of those regulations. And in the past, we had been able to evaluate regulations for only a very small number of health outcomes, including premature mortality and certain hospitalizations and emergency room visits. And clearly, the health impact of air pollution is much broader than that. It's broader than only premature deaths, as serious as that is. It's much broader than just a hospitalization for a respiratory illness. As we mentioned at the beginning, air pollution affects all the systems of the body. And so partly due to a board resolution, and of course, due to the overwhelming evidence, the thousands of studies that have been published around the world, we've been focused on adding in additional health outcomes so that we can more clearly evaluate a much broader range of health outcomes. So we started some years ago evaluating the health impacts of particle pollution on just 4 endpoints that were mostly focused on respiratory and cardiovascular issues, health outcomes and hospitalizations. We recently updated our health endpoints so that we are now calculating 11 health outcomes. And maybe we could just bring up the slide again and show that slide. If our team could do that, might be helpful just to kind of show the history of what we've done here. Again, this is in an effort to provide both a more comprehensive analysis of the health outcome, the health benefits of all the work we're doing to reduce pollution. When we adopt regulations on reducing diesel pollution, on different sectors of mobile sources and stationary sources, every time we adopt a regulation, we are providing a quantified health analysis to help demonstrate the benefits to the public and to the board, to our decision makers. So you can look on the left and see, these previous endpoints that were in use. And again, as I mentioned, mortality, hospital admissions, mostly cardiovascular and respiratory. Then in 2023, we added these additional health outcomes. And that means that we were able to identify, partly through a lot of work the EPA had done, all these additional ways that particle pollution is impacting the public. All these different types of health outcomes that all cause distress, and they, of course, end up causing huge economic costs to people, because people are paying for the hospitalizations, the medical, the medicines that they're using, just all these costs of illness that are resulting from all these different outcomes. I mean, asthma is, of course, something. I mean, all of these are of concern, and all these, some of these affect children's populations specifically, and some of them affect more adult populations. So now, and as you can see, we've gotten into being able to estimate hospitalizations, for example, from lung cancer incidents, and we're estimating hospitalizations from Alzheimer's disease and Parkinson's disease, because again, air pollution affects many systems of the body and causes a wide range of illnesses. And the finest particles, of course, pass through the bloodstream and affect other parts of the body, including the brain. And that's where we get into neurodegenerative illnesses. So now,
Okay, can I say this? Can I say this real quick? Bonnie, you're justified. I understand you justifying your research, but you're not justifying our reality. In West Oakland, between the 3 freeways, we do not have one private doctor, but we got 3 veterinarian doctors. We have one health center. This work, I understand you justify doing the research, but that's not everybody's reality in the state of California. And I'm saying there got to be some balance and equity here, and understanding what people actually need or must have. In South Central, there are 24, and that area is 24 medical service on one hospital. That is not, this research does not support the needs of the people in South Central compared to other side of in West Hollywood, where they got about 1,500 doctors. So that I'm saying your research does not support people's lived experience. Good that you're able to do that, but where's the equity based on lived experience? Yes, we die. We have high rates of cancers. We have high rates of lung problems. We have high rate of diabetes. Well, how does that relate back to services, medical services to these communities? That's I'm talking about. The research needs to be more proactive to where people are, and same thing said 30, where people are and where people's needs are. The research got to have some real lived connections.
Those are great comments. Thank you for those comments. Those are definitely the kinds of comments that are really helpful to us. And just know that as we also, as part of our work, we are looking at how we can better incorporate some types of community factors and vulnerable population, and the kinds of concerns that you raised. Thank you for that input.
Thank you, Bonnie. I see that Kai has their hand raised. Kai, please unmute yourself if you want to provide a comment.
Hello, this is Kai Wu from UCI Advanced Power Energy Program. First of all, I would like to thank for these thoughtful details about the updated health endpoints, which is very beneficial to our updated framework following CARB's methodology. I just want to ask about several previously used health endpoints, for example, about the premature deaths. I asked on the chat, and I appreciate the response from the CARB staff regarding the currently used, which is the reference in 2009. I would like to ask, does CARB also consider to update the premature death mortality health endpoints based on EPA's documents? Because we have been seeing lots of new studies have been shifting from this reference to another work by Turner et al. In 2016. And also, I also want to add this point as we are quite clear about the newly added endpoints that shared today and also in 2023. But we are a little bit confused about the some very fundamental health endpoints that CARB used in very early stage. So I want to ask, do we have full details or any documentation that can list all the current health endpoints that are used in the long-term PM exposure health benefits estimation? Thank you.
So Arash, can you answer the first part?
Sure, yeah. Thank you for that comment. We are considering moving to the more updated endpoints from EPA. And the EPA, in their latest TSD, they are already moving from Turner and Wang et al. To Pope and Wu et al. Actually. So it's evolving rather fast. And because of the sensitivity for premature deaths, we want to go through a comprehensive review for that endpoint before we deploy that. So thank you for that comment. We are considering moving to the newer endpoints from EPA. Pradeep, you want to answer the second one?
Mm-hmm.
I just want to add just real quick. I mean, we're looking at all this. And so at this point, it would be helpful if folks could submit if there are specific studies or recommendations they have to submit those. And then we can look at those and include that in our process as we go forward. Thanks.
Thank you.
Thanks, Bonnie. And I just shared in the chat. So two things, we have the English version of the slides available. I know that's not as early as folks would have liked, but it's there for your reference now. But also to answer your question, the full methodology and including the statistical estimations, uncertainties, things like that are on our website. And I just posted the link to that as well. We'll be developing an analogous version for the new updates that we're proposing today as well.
Thank you. I appreciate it.
Mm-hmm. Any other questions? I don't see any raised hands, and I also see that all the open questions have been responded, and or we'll get to them. We'll cover them in the bulletin. So with that, I will close the workshop. Thank you for your time and feedback. That was really important for us to hear, so I appreciate you sharing that. If you didn't get a chance to share your thoughts today, you can provide comments online by November 21st. If you have questions, you can email me at this address. And then just shared the link to provide a couple of comments in through our online portal. With that, thank you everyone and have a great rest of the day.
Thanks everybody.